All right, so morning everybody. We are going to start having a look at facial and mandibular fractures. All right, so today we're going to be looking at a lot of x-rays. And we're going to be looking at a lot of x-rays where when you look at them, you're going to be like, everything's fine here. Why is this idiot showing us these x-rays? And then we're going to look at them a bit more closely and you'll be like, oh my God, this person is not okay. I would have sent this person home. And the reason for that is when you go to medical school, they do not teach us how to look at facial x-rays. Agreed? Can you remember ever having a lesson on facial x-rays? Sometimes when you pass the dental department, if they had a combined dental school, you'd see people looking at facial x-rays and you'd walk past and nod your head like you knew what they were talking about. But in reality, you had no idea what was there. Okay. So big question. Yeah, I mean, mandible, we know what's the mandible. But I always ask people, what is the face? I mean, really and truly speaking, what is the face? If we really look at it. Sorry, I just want the guys to also, all right. I just want the guys to be able to see what I'm talking about a little bit as well, right? So when we talk about the face, what are we talking about? Are we talking about all of this? Are we talking about this? What is the face? An interesting question, because we all wake up and look at our face, but medically speaking, what is our face? So this is our skull. This is our jaw. And the bones in between are our face. So our face is actually this part, medically speaking, right? Colloquially, this is our face, right? So when we talk about facial bones, we're actually talking about this area here. Okay, so how many patients do we see with facial injuries every day? One, half, once a month, once a year? No, we get so many patients in our emergency departments who come in with facial injuries. Agree? Facial hits, facial stabs, people are involved in fights, people are involved in accidents. The face can get hurt at any time. Yet ironically, when we are studying, they don't teach us how to look for injuries. And if your patient's face gets injured, they are stuck with either serious problems related to their eyes, related to their sinuses, possibly even life-threatening, it's hit the brain, and you don't know how to look at it. And that's not your fault because nobody's ever taught it to. Okay. Whereas take a dental student, and a dental student in their third year can already tell you very in-depth stuff about their face. Okay. Come sit, guys. Don't worry. We're just talking about what's the face and why are we talking about the face. Okay. So today we're going to learn how to look at those facial x-rays. We're going to go through a bit of the mandible as well. And then next week we've got a part 2. We're going to cover it in a bit more depth as well, right? A little bit more theory and things like that. But the first thing we need to understand is what is the face. Okay. So I'm just going to hide this panel for now. Just wanted people to see that. And then we'll take it a bit further. So when we're talking about the face, this is what we are talking about, right? Or when we're concentrating on this area, right? So we are talking about this. So this is the anatomy of what we see, right? So we see the frontal sinuses, we see the 2 orbits, we see the nasal and ethmoid air cells, the maxillary sinus, maxillary antrum, and then this bone here is known as the zygoma, right? Everybody remember the zygoma, right? So it's made up of the arch and the body, okay? So that's basically what we look at. Now, question I like to ask everybody, why do we love looking at people on covers of magazines? Why do they hire actors and actresses? Because they have beautiful cheekbones, agreed? So the next time you're admiring somebody, in whatever form it may be, all you're really doing is admiring their zygoma. And that's it, all right? So some people have very lovely zygomas. Some people do not, which is why I feel very bad that you guys have to look at my face for those first few seconds of the video, because I have terrible zygomas. I'm never going to be on the cover of Men's Health. I'm never going to be on the cover of Ugly People because I'm too ugly to be on the cover of Ugly People as well. They won't sell any magazine. But you get the point that I'm trying to make, all right? So if you're still struggling to imagine what we're looking at, imagine somebody with high cheekbones. So that's the area that we're looking at, right? So that's basically it, right? And then we also covered just a little bit over here, which is called the alveolar ridge, okay? But the main bone that's formed over here is the zygoma, okay? Now, the one thing I want you to notice, now take out all of these things. What is this? It's a ring, agreed? It looks like a ring if you really look at it. It's a ring with just a few projections coming on. So have you ever owned a ring, eaten a donut? Can you break it in one place? Is it possible to break a donut just in one place? Think about it. Or to break a ring in one place without damaging anything else. Very difficult. Agreed. If you take any sort of ring structure and you try and break it, it will normally break in 2 or 3 or 4 or 5 places. Now that's the same story with this thing here. All right. When the face gets injured, it's very rare to have an isolated facial fracture. Just remember that. What it means is that if for any reason you find one, chances are there is another. And we're going to get into it in more detail next week, but this tends to fracture in 2 to 3 places. The reason for that, the eyeball is in the orbit. Agreed? Can you regrow your eyeball? No. If it's damaged and it's gone, that's the end of it. But can you regrow bone? Yes, you can. Right. So it doesn't matter whether you believe in God or evolution or the devil or whatever it may be you worship. All right. But it makes sense that the way this place is designed, if there's a force applied to the eye cannot regrow. So the eye takes all of that force and then distributes it to all the bones around, and those bones fracture. All right. So when force is distributed, it's distributed evenly. These bones have specific fracture points. And what you learn is that the bones tend to fracture in the same places over and over again. Okay. So like I say, that's just a bit besides the point. We're actually going to get into that in more detail next week. But just remember this. This is basically what we're looking at. All right. Okay. So how do we X-ray this area? We use something called an occipital mental X-ray. All right. So what does an occipital mental X-ray mean? Sorry, I just want to put this up. So where's your occiput? There. Where's your mentis? Here. So they're taking an occipital mental X-ray. All right. So they're basically shooting through from there to there or from there to there. All right. But what it does is it gives you a very brilliant view of the face. All right. And what we do is we use, well, I'm going to show you another one, but this is the first one that we use. These are the 3 lines that we use to actually look at the face. All right. So what I want you to do, have a look at line 1 and then just have a look at it. And then I'm going to show it to you on my face so you can imagine what we're looking at. All right. But basically line 1 starts from here and it then tracks along the top of the orbit and then just repeats on the other side. So that's what line 1 is looking at. Okay. So when we're talking about line 1, we're just talking about the top of the orbit. Line 2, which is this line here, which looks very scary at the moment. What the heck is all of this? Essentially, all that we're looking at the top of our cheekbone, all right? We're then following to the bottom of our orbit, and then we're looking at the side of our nose. That's it. That's all that we're looking at, all right? This little area over here. In line 3, what we are looking at is we are looking at the bottom of our cheekbone, and we're following on to our alveolar ridge. So we're just looking at that part. So you can see why they didn't teach you this in med school. It's a bit complicated. Agreed? Am I right? No lecturer has the time to really teach you this. They can teach you about liver malignancies for 5 months, which you see once a year. Wilson's disease, which you see once every 10,000 years. They won't teach you about this that you see every day. All right. So you kind of get the idea of what we're going to look at. Right. Now, don't stress. If you can't remember this, we're going to go through it on each X-ray. All right. And try and figure out what it is. So the good part about an occipital mental X-ray is it gives you a very good idea of what's happening in line 1 and line 2. So in other words, it shows you what's happening at the top of the orbit and at the bottom of the orbit. The problem is it doesn't always show you very well what's happening at the bottom of the zygoma. Okay. So in order to get through that, sorry, let me just get that a bit smaller, sorry. So in order to show you that, we have something called an occipital mental 30. All right. So what does that mean? That doesn't mean that you have 30 X-rays. It just means that they tilt the patient's head 30 degrees. The reason for that is now they're shooting through a bit more from the bottom. So can you see, when you look at it from this side, you get a very good view of what's happening here. You don't get such a good view of what's happening on top. The reason why I mention this is it depends where your patient is injured. That's where you'll ask for which X-ray. So if you have injuries more around this area, you'll ask for what they call an OM X-ray, occipitomental. Your radiographer knows what it means, all right? And if you suspect your injuries are more in this area, you'll ask for an OM30. Okay, so just remember that. Very good. And this is essentially what an OM30 is kind of looking at, all right? So here we have the orbit, we have the maxillary sinus, we have the zygoma, all right, which is going all around there. And then this is the TMJ, or the back of the mandible, and the coronoid process of the mandible. Okay, so if you're having trouble imagining what's there, yeah, I want you to just be, in other words, whenever you look at a facial X-ray, you must be able to imagine what you are looking at. Do you get what I'm saying? The reason why I mentioned that, all of these x-rays that we're going to see today are beautiful x-rays. They are put in textbooks, they are published because they look so lovely. And you can see everything so beautifully. But we know what happens. 2 o'clock in the morning, the radiographers just had a nap, just got up, forgot how to position the patient. All of a sudden, they look at it, what the heck is an OM X-ray? I can't remember. Overexposed, underexposed. So in other words, it can become difficult to look at these things. Okay, so you need to be able to imagine what's supposed to be. Okay, and then we'll talk about what you do towards that. Let me just hide this a little. So what I've shown you so far are some of the lines that we can look at. But 2 o'clock in the morning, you've been on your feet for 14 hours, 16 hours. You don't have 5 minutes to go through all of these lines and look at that. So is there another way? Yes. And we have these. They are called the McGregor-Campbell interpretation lines. I remember what I told you. Generally, the fractures occur in the same places over and over and over again. Agreed? So what these guys did, McGregor and Campbell, I'm saying guys, it could be two ladies too. I'm not trying to be sexist, sorry. But what they did was they looked at the most common areas for fractures to occur. And they said, okay, let's just make a simple set of lines instead of having the complicated lines, because we know that most fractures take place along there. All right. So what they did was they simplified line 1 to, instead of being curvy, being straight. Okay. But it's still just looking at the top. Okay. With line 2, instead of following every little contour, we kind of just follow across, just like that. All right. And by doing that, what you're going to do is look at the most common areas. And then line number 3, or the green line in this case, just looking across the most common areas to have fractures there, right? So we're going to use both methods, and you'll find the one that you prefer, all right? And then this is your mandible, so you know what your mandible looks like, all right? So your TMJ and your coronoid process, all right? So this one doesn't have a fracture, don't worry, okay? So let's try one, and let's see. Okay, can you see the X-ray properly? I don't know, I can't look at that screen, so I'm not sure how it's projecting. Ah, that actually looks quite nice. All right. Do you want to switch off the lights? Maybe you guys can see it a bit better. All right. Okay. Right. So let's start. Okay. So what you're going to do is follow my pointer. Can you see my pointer? It's there. Okay. So let's start with line 1. Okay. Come. You're late. Today you're going home at 6 o'clock. All right. Excellent. She's agreed. Huh? No lunch. But no, I'm joking. Come sit. All right. So let's start with line number 1. Right. So this is an occipital mental X-ray, right? Which means that we're looking for injuries more in the mid-face. Okay, sorry, let me just put the video panel on so people can see what I'm talking about. So let's start here with line 1. So we're just going to follow the top of it. Do you notice anything? Or does anything look strange or out of place? Not really. Agreed. Everything kind of looks intact. Everything looks okay. And what I'll tell you guys is generally there's not many injuries that occur across the top of the orbit. It does happen. The most common place for the fracture is here, all right, which is called the frontozygomatic suture. Okay, so you can see this little line over there. Generally, if you are going to get an injury here, it tends to be around there. So if you were to use line 1, I mean the simpler one, they take you there, and you notice they've got a little asterisk over there. The reason for the asterisk is pay special attention to that area, because that's where you get a lot of injuries. All right, so we don't see any injury. Let's try line 2, both of the line 2. So let's start with it here. All right, so let's follow the top of this one, and then we go across to the bottom of the orbit, and then we go across there, and we follow across on this side. Okay, so is there anything that you notice that looks a bit odd? Now I'll tell you the injury is on this side. All right, so let's follow the normal side. So look at the normal side, look at it critically. Okay, we can see how nicely we cross across, how nicely we come across here, and then how nicely we come across there. And then what do we notice? What's happening here? Have a look at this side. Now compare it to that side. Not the same, eh? What's wrong? What's not the same? Let's draw it and let's see. So the first thing we notice, there's a fracture there, and there's a fracture there. 2 minutes ago, this patient was going home in AD. Agree? All right. But what else is going on? Let's have a look. And let's just see if we follow, let's clear that. All right. So let's just see if we follow the simpler line and we went across. So you can follow it. And if you follow the simpler line across, can you see? Now you notice the fractures again. All right. Okay. Let's follow line number 3. Okay, so this time if you follow line number 3, the one thing we'll notice, it seems okay. All right, the injuries generally will be seen around there. There's one other thing to notice. Compare the two sinuses to one another. Do they look the same? No. Which one looks different? This one, isn't it? What's happening over there? What's this? It's an air fluid level. Agreed. Okay, so what does an air fluid level tell us? That there's fluid there, isn't it? And we know that we've got an injury on this side. Okay, so where is fluid going to come from? Fluid's not going to leak from the cheek into the sinus. So the only place it can come from is the orbit. Agreed. So that means there must be a fracture in the orbit here somewhere, even though we can't see it too well. So what's happening is that floor fractures sometimes, all right? And all the contents, the fluid, the fat, everything starts falling down into the sinus. Okay, so sometimes even if you can't make out the fractures, they may be very small, but if you see a fluid, air fluid line in that sinus, now in the setting of injury, of course, all right, facial injuries. If somebody's got an ankle fracture and you somehow take a facial x-ray and they've got this, please don't diagnose them with a facial fracture, okay? I'm just saying in the context of facial, that means that something has happened. We're going to cover it in greater detail next week, but I just wanted to show you guys this now. Right? Okay, let me just clear all the drawings. All right. So what are you going to do for this patient now? That's the question. Very good. We found all the fractures. Give him Panado and Brufen, send him home. Or if you're feeling really sympathetic, we give him Tramadol. No. What are we going to do? What's your next step? CT. All right. Because we can just see the outside. We can't see what's happening on the inside. And remember what I told you guys? The forces get distributed evenly from the eyeball. So we don't know if there's other cracks on the inside and how far do those cracks extend. Okay, so once you have something like this, that patient needs CT. Oh, is everybody in? Sorry, I was just checking there's nobody waiting. Okay, so these are some important clues that you can see in terms of facial x-rays. Now this patient actually has quite a severe fracture. Once the orbital floor collapses, sorry, I'm just putting this for the people on Zoom, all right? So once the orbital floor fractures, all right, imagine the floor you're sitting on now suddenly fractures and opens up. You're going to fall through it. Am I right? So what happens is your eyeball starts falling through that crack. The muscles associated with the eyeball start falling through that crack. And then they all kind of get wedged inside there. So what's going to happen to that eyeball? It's going to leak and leak and leak. And eventually, it's going to be of no use to the patient. So what do they have to do? They have to remove it. So in other words, if you put NAD, go home, this patient is going to come back in 2 weeks with a useless eyeball. Agreed. We'll cover some of the clinical signs next week, but I just wanted to explain to you guys that it is quite serious if you miss it. Okay. All right, let's try another one. I can see you guys are already tired. Shit, another one. We've got quite a few to go through. So let's follow the lines. All right. So what we'll do with this one is let's follow the easy lines. Okay, the ones that you can use at 2 in the morning when you're tired, or 8 in the morning when your coffee hasn't kicked in yet. All right, like for Chani over there, you can see. All right, so let's try. So line 1. All right, so they tell us to concentrate on that part. Let's go across here. Do we notice anything? Especially if you compare that side to that side, the switches. What do you notice? Can you see that it looks a little bit wider? Slightly. All right. So it's giving us a clue. It's telling us something's happening on this side. All right. Let's follow line number 2, the simple one. All right. So we go through the middle of the zygoma. Let's come across here, across there, and then we come across here. And what do you notice if you compare the two sides? Specifically, if you look at the zygomatic process, what do you notice? Do we have one? Look at that. And then look at that side. Where the heck is it? It's missing. Agreed. We don't have a zygoma. Did the patient remove it himself or herself? No. All right. So there's some sort of trauma that's going on over here. All right. And then if we look at line number 3, which takes us across here, right, there's not much to notice besides the fact that if we look at the bottom of the mandible, can you see it's not connected to anything? All right. So we've got a fracture that extends through there. It extends through the zygomatic process, and we don't know where else it extends on this side. All right. If we want to be very critical, we can see there's a little bit of fluid in the sinus. So there's something going on over here. So what's your next step for this patient? CT scan, very good, because the CT is going to tell you exactly how bad this fracture is. Now, where is the zygoma? It's there. It's just pushed right in. Okay, so if you can imagine a cheekbone that's completely collapsed inside, do you think you'll be able to see this clinically? No. What will you see? Swelling, severe swelling, extreme swelling. So that's another clue that tells you something's gone wrong with the face. Okay, so let's try another one. Anybody want to volunteer to look at one? Let me hide all of this. Wait. Video panel, hide floating controls. Okay. Anybody want to give it a guess? Go. This is actually an easy one. If you can't get this one, then we'll restart the whole lecture from the start. Don't worry. Everybody does that at all these lectures. They do that weird. Yeah, I can see it. I can see it. It's like being on Who Wants to Be a Millionaire, and they ask you, do you know the capital of Mongolia? Yes, I do. Can I have my million? All right, let's try it. All right. So this one here, you can see this is an OM30, right? Which means that they are looking more at the bottom edge, right? So we're not going to worry too much about line 1, but let's look at line 2. So let's just look at it from here, right? So line 2 in the OM30, you can still follow it quite a bit, but look around it. What do you notice? What do you see? Do you see anything? Not really, eh? Not really. But here's a patient who's sitting in front of us with severe pain, not feeling well, severe swelling and things like that. So let's go to line number 3. We go across there. Again, we don't see much. Agreed. There really isn't much. So this is the time when you say to yourself, but look at this patient, because even on the X-ray, you can see the amount of swelling. The swelling is quite extensive, right? So that amount of soft tissue swelling means that, okay, on the simple lines, I can't see what's going on. Let's look at it in a bit more detail. Okay, so now let's follow line 2 properly. Let's follow each segment of it. So let's come across here. So we skip across there, come around there. What do you notice? Can you see the bottom of that orbit? What's going on? What's going on there? Can you see that? Is that a fracture line? It is. Let's go across here. Morning. Let's go across here. Let's look at this orbital flow. What do you notice? Okay. It's not connected. It's a fracture. Agreed. Here you can actually see the fracture line now. So it doesn't mean that if you don't pick up anything on the simple lines, don't go through the rest. So even if we follow here on the arches, if we follow line number 3 properly, okay, there's not much to see, but we may see something. So what's happened to this patient's face? I mean, if you had to look at this, you can see they've got a fracture there and they've got a fracture there, which if we had to, sorry, let me just get this. So if we had to look at it, so they've got a fracture there and a fracture there, and we can see that everything's sort of pushed down. Here we can even see a nasal fracture there, okay? So what's happened to their face? This entire portion of the face is basically, it's been pushed back, all right? So I mean, somebody really strong, straight, agreed. It was so powerful, it didn't even fracture anything else. The entire face just said, oh shit, and just went back like an inch, you know, damn it. That's like a Mike Tyson punch, all right? So the entire thing's fallen backwards. So are there structures behind that as well that we can't see? Of course. So what's your next step? CT scan, not NAD, go home. Agreed. What's going to happen now? This patient's in the danger of losing both of his eyes. Agreed. In 2 weeks' time. That's not a minor thing. That's quite a major thing. All right. And how are they going to solve this problem? That's when they call the maxillofacial surgeon, who comes out in his private helicopter to your hospital to do the operation for 45 minutes and then refills his private helicopter with extra fuel because he's going to go via Sun City for an hour. All right. What I'm trying to tell you is if you want to make money, become a maxillofacial. All right. Because you will make a shitload of money. Okay, so let's try another one. Yeah, no problem. Oh, you want to see the mandible as well? Yeah, sure. So if you follow here, on the OM30, it's a bit more difficult, but you can follow the mandible, that's for sure, right? So we are following the coronoid, we are following, but yeah, actually now that you mention it, yeah, you're 100% right. There is a fracture over there. I bow my head to you, Dr. Vishan. See, I fell into my own trap. I always tell everybody, once you found a problem, don't stop looking. And I did the same. Okay, but yeah, you're 100% right. Okay, so there we go into a mandible fracture. In fact, from here, you can even see how extensive the fracture is. So well done. I like that. Good. Excellent. All right. Now, let's try another one. Okay. I'm looking at the mandible first to make sure I don't miss a fracture. All right. So let's try the simple ones. Okay. So let's look at the simple line. All right. We just go straight across. Do we notice anything? Not really. Agreed. What do we see here? Let's come across to line 2. Do we see anything? Not really. Agreed. Kind of looks normal over there. Let's look at line 3, which is sort of going through there. Do we see anything? Not really. Agreed. I put these here just to make you guys understand that while the simple lines will show you a lot, they may not show you everything. All right. So you got to sometimes do both. Now, let's look at the more complex lines. Let's go across here. And again, do we notice anything? Not really. Agreed. But there's something going on over here. Even if you haven't looked at the rest of the X, there's something going on. It's like a soft tissue swelling. Agreed. It's quite an extensive soft tissue swelling. Even on this side of the head, you can see there's a lot of swelling. So we know that the problem is on that side. Okay. Let's follow line number 2. So the top of the zygoma, bottom of the orbit, across the side, coming across here. Do we see anything? Not really. No, I know you're trying to find something, but I'm telling you, there is not much. It kind of looks the same. And when we come across here to this line number 3, again, we don't really see much. But here you have this patient in huge amounts of pain. There's odd swellings, massive swellings of the cheek. Are there other things that you can look at? Was there something else that we looked at recently? Axillary sinus. Did we look at anything else? Okay, you guys y'all are really tired this morning. Eh? The maxillary sinus. Look at the maxillary sinus. Compare the two. What do we see? How does this one look? The side without the injury. Is there anything there? No. But look at this one. What's going on there? What's this? What did we say it's called? Air fluid level. Very good. And any idea what's going on here? This is actually the tissue from the orbit that's sunk down. All right. So it's something called a teardrop sign. That's not important. The important part is sometimes these fractures can be so subtle and so minute that you may not even see them by following all the lines. You've got to look at your auxiliaries, if I can put it that way. All right. So don't ever forget to look at the sinus itself. Now remember, this is in the context of trauma. This is in the context of severe swelling and pain. So even though you can't see the fracture, chances are there is a fracture here. So we need to send this patient for a CT scan. Very good. Okay, excellent. You guys getting the hang of it? Okay. Now, I've also mentioned this because sometimes, even if you look at everything, you may not be sure. Okay. And that's the point where you ask for senior help. You say, listen, this patient really doesn't look well. I'm looking at the x-ray, but I can't make it out completely. Can you please have a look at it? Do you get what I mean? And somebody senior may look at it and say, okay, I'm also not sure. That's when you involve the radiologist. Okay. And we take it further. We are looking at this from the context of an emergency department where we have lots of patients. We have lots of pressure. We don't have half an hour to sit with an x-ray and study it in detail. So we've got to learn these techniques to try and pick out problems and then take it further. But a radiologist can sit with this for half an hour, 45 minutes, order a CT, order an MRI, order this, order that, even do ultrasounds of the sinus and the orbit and things like that. They've got time to look for. Do you get what I mean? Okay. So that's why we are just trying to learn these few things. All right. Okay. So let's try another one. This is a scary looking X-ray. This is like the type of thing you see in your nightmares. But anyway, all right. So let's go through it again. All right. So let's look at line number 1. Do we see anything? Not really, eh? Kind of looks okay. Let's look at line number 2, the simple ones, all right? So we're just going across there, trying to see if there's anything. Do we notice anything? It's difficult because we've got these cells. This is an overexposed X-ray, all right? So we're actually seeing the mastoids at the back, okay? All right, let's look at line number 3. So we're going through that part. Do we see anything? Not really, eh? Let's try our more complicated lines. Let's follow it absolutely exactly. Do we see anything? Not really. Eh? Oops, sorry. Let me go back. That was my mistake. Let's go to line number 2. Let's follow across. What do we see? Anything you notice there? Especially if you compare it to this side. Okay, anything you notice there? Does it look okay? That's what I'm asking. Or does something look weird? Something looks weird, all right? Even if you're not going to say it's a fracture, but let's just say something looks weird. Let's look at line number 3, but difficult to see because of everything. Do we see anything? Not really. Shall we look at our sinuses? Do our sinuses look the same? No. All right. Can we see the air fluid level inside? We can. All right. There's even a bit of tissue. And there's one other thing that we notice. This is another sign that I wanted to teach you guys. Let's look at these orbits. Do they look the same? Just concentrate on the orbit themselves. What looks different? Yeah, very good. So that's not supposed to be there. Agreed. All right. Any idea what that's called? That is called orbital emphysema. All right. So orbital emphysema is not supposed to exist. We're not supposed to have air in our orbit. So what's the point? Where would air come from and get into the orbit? Yes, one of the sinuses. Very good. So let's say you are not sure if this is a fracture. You forget to look at this, or it's completely clear. But you've got an orbital emphysema. It tells you there's a fracture. Agreed? Something is leaking from somewhere. It could be this sinus, it could be here, it could be there. But one of the sinuses is involved, and it's actually leaking air into the orbit. So what's your next step? Ah, very good, right. Okay, we're going to be sending 10 CTs today. I can tell you that much. Everybody's going to have a facial fracture today. Shit, Dr. Mohammed told us. All right. But so what I'm saying is these are the subtle signs sometimes that we can use. Will this guarantee that you find every fracture? No, but you'll find 99% of them. All right. And the other 1% are those where it's so clinically clear that this patient is not okay, but I just can't see anything. That's when you're going to ask for senior help, radiologists, possibly just CT without anything obvious on an X-ray. Okay, good. Right, let's try another one. This is a mandible fracture, by the way. So we're just going to cover the mandible a little bit. Okay, we're going to cover it in more detail next week, but I just wanted to show you guys this for now. So is there a fracture? Where is the fracture? Ah, very good. Yes, there's 2 fractures. There's one here at the coronoid process, and there's one going through the mentis, or the main body of it. All right. So when you're having a look at the mandible, always remember you've got to look at the entire thing. All right, just to see what's going on. Now, what's the problem with this segment at the moment? Is it attached to anything? No. Okay. So does it have the possibility of collapsing? Yes. What's the only thing that's keeping it going? Tongue. That's the only thing. It's just the glossal attachments that are actually keeping it in its place. All right. So what happens when this patient lies back? What's going to happen to that segment? What? Fall back. Agreed. So is this patient in danger? Yeah. Okay. Now it's a more of a problem when they get fractures here. All right. But anytime you have a double fracture, don't just send the patient home. Okay. What's another thing that we're worried about? Remember we talked about it with human bites. What's the furthest part of our body? Mouth. Agreed. So if you see a fracture like this, are you worried about whether it's an open or a closed fracture? Yes. Do you check it? No. I know this. Nobody checks for open fractures in the mandible. I don't know why. But is it important? It is. Agreed. So whenever we get a fracture of the mandible, doesn't matter, but more especially around this area, always check, is it an open fracture? The reason being it changes the management completely. So if it's not an open fracture, that's fine. Patient goes to the dentist book them for max fac, they go down, they get their operation done. But if it's an open fracture, this patient is at high risk of having osteomyelitis of that mandible. Okay. And once they do get osteomyelitis of that mandible, you sentence them to quite a few months in hospital. All right. Because osteomyelitis from there is now not with just 1 or 2 skin bacteria. I mean, you're talking about hundreds of bacteria that you've introduced there. A lot of the time, these patients need removal of the mandibles, grafts, metal plates. You know, there's a lot that needs to be done in order to sort them out. So how do you prevent that? Admission, IV antibiotics, and then they go to MaxVac quite urgently. Okay, so just remember that. Now, I'm skimming over this a little bit because earlier in the year, we actually did a presentation on facial injuries, where I cover all of this in much greater detail. So if you guys want to learn more, you'll find, I think we did it somewhere in January or February, okay, where we talk about this in much greater detail, okay. But just so that you guys understand, that's how it is, okay. Right, let's try another one. So let's try and find the fracture here. Can anybody see it? Ah, very good. That's the screen, you're right. Name it, at least tell me which section. Top left, top right, bottom left, bottom right. Yes, that's that side of the screen, but you're still not saying anything. Where is it? Ah, there we go. All right. On the other side. Yes, very good. So we've got two fractures going over there. All right. So it's quite important to look at the entire X-ray. Okay. So it's very easy, for example, to get lost in something like this and say, ah, there's a massive fracture, and I forget to look at the rest of it. Okay. So whenever you have a patient and you find one thing on an X-ray, don't just stop. Carry on. You'll be amazed what you can find. Is this patient also at risk? Yeah, this patient is also at risk. It doesn't mean that they will definitely have airway compromise. That's not what I'm saying. But what I'm saying is there is a possibility of airway compromise. So even if the expert, so in other words, this patient would be in our setting, for example, seen by the dentist, would discuss it with the maxillofacials. This particular one doesn't have as much risk of collapse. So they would advise the patient to nurse upright at home. They'll probably call the patient a day or two. They do a more urgent fixation, all right? But the thing is that that's not your call to make. Do you get what I'm saying? It's somebody more senior has to make that call. Okay, so always remember, whenever you're examining the mandible, look through the entire thing and always check whether it's an open fracture or a closed fracture. All right. Is there any way to check if your patient has a fracture even before you send them for x-rays? Yes, there are some ways. Number one, you can look under the tongue. All right. If the tongue has a hematoma, or what we call a sublingual hematoma, that's almost pathognomic of a mandibular fracture. Okay. And again, I've got pictures of that in the older one. Okay. But remember, that's in the setting of trauma. Okay. Outside of the setting of trauma, coagulopathies, bleeding disorders, basically. All right. All right. What else can you use? Number one, all of us, we can rotate our tongue between our two molars. You can do it now. They're not painful at all. But when anybody who has a fracture, ask them to do that. Oh, they can't do it. It's extremely painful. All right. The other thing you can do is you can take a tongue depressor, make them bite on it, and you and I, we can bite it until we can break it. But somebody who's got a fracture, it's impossible. All right. So sometimes if you're not 100% sure, am I seeing something, am I not seeing something? Is it an artifact or something like that? Those are also just clinical tests that you can do. Okay. But with the tongue depressor, you do it on both sides. All right. Because if the fracture's here and you do it here, it won't pick up anything on that side. Okay. Got it. Good. I don't know if there's any more. No, that's the end of it. Okay, right. So let's hide it. So the thing what I'm trying to say is that facial fractures can be difficult, right? Because all the examples we saw are very lovely x-rays. But as I mentioned, you can have very subtle changes. You can have very subtle things that may show up. So it has to tie in with the clinical picture of the patient as well. And what are the clinical features of a fracture? Pain, swelling, bleeding. All right. So if you have a patient in significant pain, patient significant swelling, or has a significant amount of hematoma, you have to suspect that there is going to be a fracture there. If you are not sure, right, you dozed off for the middle 15 minutes of this lecture and you're not sure, then you ask somebody. And if they don't know, let them ask somebody, But if you decide there is a fracture here, then your next step is CT scan, right? Well, the CT scan will tell us the extent, right? And the reason why we are worried, two things, all right, three things. Number one, function. Okay, function of the eye specifically, right? Now, in the older lecture, we talked specifically about fractures of the orbital base. When you have a fracture of the orbital base, you have the inferior rectus muscle that gets trapped there first. Okay, so your patient has some clinical signs like they can't look up and things like that. But the eventual outcome of that is desiccation of the eye, drying out of the eye, okay, which is not something the patient can come back from. You have damage to the sinuses, entry of infection, possible osteomyelitis with quick spread to the structures that are posterior. So there are things that are quite worrying, things that can really affect this patient. As we come towards the middle, epistaxis, right? Especially posterior epistaxis, what we call Woodruff's area. You have some massive arteries that are running through there. And if there's a fracture line close to those patients can have quite a severe bleed, all right? So these are the types of things that we worry about. So it's function, it's potential for harm. And the last one is aesthetics. Even if a patient only has a crushed zygoma on the one side, they're never going to look right. Do you get what I mean? And we all wake up. The first thing that we look at, we do not look at our toes, all right? Okay, the guys look at their morning wood, but that's a different thing, all right? And so after they're done with that, they go and we look at our face, okay? But what you get what I'm saying, all right? The face is one of the most important things. So you have to make sure you look after your patient's face, be it with suturing, x-rays, whatever it may be, okay? Any questions, anything anybody's worried about? Do you want to re-look at another x-ray? No, everybody happy? Everybody on Zoom happy? Okay. So next week, we're going to look at a few other examples, all right? What I'll do, I think I'll put the old lecture back on as well, all right? I'll post it on the group, so those who haven't seen it can watch it again, all right? And then it kind of marries the two things together. That's why I didn't spend too much time on a lot of the theory today. We were just looking at x-rays, okay? So I hope you all enjoyed it. I hope it was okay. I know you guys were on call last night, eh? That's why I look so tired. Sorry about that. Okay. But anyway, it's just until 10 and we already wasted an hour, so it's fine. Okay. All right. And then to the people on Zoom, thanks very much. We'll post this in a little while. But yeah, bye. Let's get back to work.